CataractCoach.com, podcast series, episode number 109 with Dr. Steve Sarkisian, innovating glaucoma, advancing surgery, and enjoying life. Welcome back to our Cataract Coach podcast. Today, I have a very special guest. That is Dr. Steve Sarkisian from Oklahoma. Steve, welcome to my podcast.
Well, thanks. Today, I'm glad to be here. This is great.
Now, if you are going to Google about Dr. Sarkisian, just keep in mind, there's another Steve Sarkisian. No, the glaucoma expert does not coach football in Texas.
No, he was just a quarterback, so, but this is being in Oklahoma, and since he's now the head coach at the University of Texas, I've had every day someone asks me, usually, are you kin to the doctor, to the coach at University of Texas? I'm just like, no. And then, I have to basically tell them that it's like the Smith of Armenia is Sarkisian. So and they're like, well, he pronounces it wrong. I'm like, well, no, we're both wrong. It's probably Sarkisian. Sarkisian and Sarkisian are probably both wrong. And I know this because when I went to Armenia to serve on like a little medical mission thing, the residents at the Malayan Eye Hospital were like, so how are you, Sarkisian? And I'm like, is my nose not big enough for you people? And they're like, no, finally I'm like, is it because I don't have to shave my back? Is that what it is? They're like, no. And they, I'm like, they're like, well, where's your mother from? I'm like, well, my mother's, half Italian and half whatever. And, and they're like, oh, that is it. You're Italian. And I'm just like,
okay,
man, like, really?
Well, so being in LA, we actually have a large Armenian population. I've learned the important things, which is, of course, look at the light. Luisin Nair, so I can tell the patients, look at the light. That's obviously the most important thing we tell them, especially during surgery. But I also learned this one great Armenian saying, which is their equivalent of like, quit bothering me. It's glukas mi hartuki, which literally translates to don't iron my head. Like you'd iron your shirt, don't iron my head. I can teach you that one. That'll be a good one.
Yeah, all I know in Italian and in Armenian is like, shut up, dinner's ready.
Guarda la luce. That's the one you want.
Yeah, it's shut up and dinner's ready. That's it in those two languages. And I'm not accepted by it. But that's okay. It's good to be a little bit of an outcast, I suppose, and to confuse the folks, but that's fine. Yeah. So yeah, man, I'm so glad to do this with you. We've been friends for a while, and I think we're both sort of we love people. We love disrupt. We refuse to be boring. I think if you and I have something in common, it's the absolute hardened refusal to be boring. Is that fair?
That is absolutely fair. Plus weightlifting. We're both addicted.
Well, that is true. And I'm there, there is a physicality to being a surgeon.
Yeah.
Right. Like when I was a fellowship director, I would look at I would take the person who was an all-American, sports, whatever, tennis or anything over AOA all day long, because I knew that like, if your hands and your eyes are well coordinated, like you can, right. you will be a resplendent surgeon, especially if you're intuitive. I mean, you've trained a lot of surgeons too. I mean, the difference between an intuitive surgeon and a non-intuitive surgeon is huge, right?
Right.
It's one of the main things that we don't really talk about. It's kind of a taboo subject because, but look at, like people have talent, and then people, they do things over and over again and they get better at it, and some people are just always going to be not so great. We don't like to talk about, that the average surgeon is a competent surgeon, like we're all in the NBA as it were, but not all of us can be Jordan. Right. Yeah. And I'm not claiming to be Jordan, but you know what I mean? Like, what do you do with a person that does a 3-minute phaco and like, should all of us be judged by his videos, by that surgeon's videos? And, and how do you there's no way to address that. And, unfortunately it's the guys with the biggest egos putting these videos up like, hey, I can do this in X amount of time. And then someone from Medicare or something sees it and they're like, you're killing us. Oh, well,
Well, you actually want to be slower. So I actually made fun of myself. I put a video up in 2005, so 20 years ago, of me, early 30s, operating, doing very fast fake out. And then I reviewed the video a few years ago and said, I was a moron. Who cares if it's 3 minutes? If it's my eye, please spend an extra 2, make it 5 minutes, and make it prettier than that. We've obviously changed a bit, but yeah, you're right. No one wants to talk about in academia, especially. There's a bell curve of surgical skill, like there's a bell curve for everything else in life.
Right. The best surgeons are not in academia. I mean, I say this. Well, you just left academia, didn't you? Or you're kind of only academia adjacent now, or something.
Well, I did for 22 years. I did part-time private practice, part-time professor at UCLA, teaching the residents at the county hospital. And that was a large portion of what I did. But 3 years ago, I actually retired from that at 52. So now I just do my private practice, and now I teach the world with CataractCoach.
I love it. I love it. And which is such a tremendous resource. And
you also left academia. So you finished a glaucoma fellowship at UT, University of Tennessee, Hamilton Eye Institute. They loved you so much, they said, hey, by the way, we're nailing your foot to the floor. You're staying right here as faculty. And then after a few years, you left and went to Oklahoma. And for a dozen years, you were a glaucoma professor there.
Yeah, that's right. I mean, and it was a weird time to be in academics, but I think they knew to just let me be me. I think that's how it worked is, they knew that, I mean, part of the reason that they brought me on there was because they knew that I was going to, I don't know how well they knew this, but I think they had an inkling that I was going to break stuff, and by breaking stuff, I mean, like by changing paradigms and they knew this because, in 2003, Peter Netlin, who was my fellowship director and who's now chairman of EVMS, we started doing the express shot under a scleral flap, and you would not believe the forces of mediocrity, or I don't know, like I don't want to
the old dogma, the old mindset.
Yeah, I don't want to say axis of evil, but I mean there was a bunch of people that came out and were like, you're putting a nail in the eye. I'm going to shut you down. What you're doing is wrong. Now, they wouldn't necessarily, people have a way of not giving me crap to my face. But, it's, it all comes back to me, it's kind of interesting. But I'm like, you know what? And I learned this from Peter. I want to do things more safely. Like if there's a thing, I mean, you see enough eyes go blind from trabeculectomy. 7 to 10% of severe glaucoma eyes that have split fixation will lose fixation with the trabeculectomy.
Yeah.
Let me say it again, 7 to 10%. It's a big freaking number. And people are like, oh, just do a trab. Well, if you have severe glaucoma, you don't want to have a dangerously low pressure, especially in the early postoperative period. Right. And so with the Express, it went from a 500,000 micron hole under the flap with the sloppy 3 Kelly punch, whatever, to a fixed, fixed lumen, and you still needed to sew the flap down, but it still controlled the flow so that a pressure of 6 with a express shunt under a flap was different than a pressure of 6 with trabeculectomy, and it was just safer. And Peter and I published that data. And it demonstrated that the rate of hypotony was 5 to 7% with the Express and 11 to 15% with the trabeculectomy. And it was a big deal, and it got Alcon's attention. So we went from being pariahs to when Alcon bought Optinol, then we became prophets. It was like, oh, yeah, Steve knew this all. Yeah, that's great. But for me, it's never enough. So then the next step was abexternocanaloplasty, that was like the next, the extension of viscocanalostomy, where we were doing, which I actually never did viscocanalostomy. We talked about it, and I remember my fellows were like, well, maybe someone that's got, a small eye and high risk, you would need high risk for suprachoroidal hemorrhage because they have a thick sclera or something. Maybe they would be the one you do, but we never did one. But then, canaloplasty came out, and that was the next step, and it was just a small number of us, sort of, I don't know what to call us.
Renegades.
Crazy Jedi Knights, really, because it was a hard surgery.
Right.
But if you look at the list of people that were canaloplasty surgeons, ab externo canaloplasty surgeons. Those were all the guys and gals that ended up being the guys, the folks that were all the early clinical trials for the MIGs procedures. Yeah, yeah. So it was like a movement in that direction, and they accept the express, they accept the canaloplasty. But once we started doing, eye stents and CyPass, and and it's weird when you're the first one in the world to do something,
right?
The CEO and the medical director and the engineer that designed the Trap 360 device, basically sought me out to be the first to do their Trap 360, and I'm like, sure, bring it out, come on out. And we just kind of did it, and I asked for forgiveness later, but it was hard for the fellow and the other people to sort of process what was happening.
Right.
Is this okay? I'm like, well, sure, it's okay. This is just it's just like a scalpel. It's just like me using a different scalpel. I'm not leaving anything in the eye, and these poor guys were, like this, shaking in the corner, like they pour all their lives into this. And I'm just like, yeah, I got 4 or 5 cases. Let's go, and, and I think we went to Jimmy John's or something for lunch. I mean, it was like some inauspicious thing, but it was like this groundbreaking thing. And I just kind of let it pass me. I'm like, what do we got today? And it was awesome, and to be a part of that. And then of course the Visco 360, in 2014, they were like, we're going to do this with viscoelastic instead, and do it from the inside. So somehow I really kind of, I guess it was me that was the first in the world to do ab interno canaloplasty, because it wasn't called that. It was Visco 360, but that's what it was, and then that eventually became the Omni, where they put the two things, one catheter that did both goniotomy and viscodilation. And it's cool stuff. I mean, it's one of those things that just, and then I'd say, hey, you guys got to try this, and we've seen just tremendous results with that. But being a sort of first adopter is kind of trippy.
Mm-hmm.
And it's also with when you're being first to do certain IOLs and things, or even if you're the first one in your state, you can't overthink it. You can't drink your own Kool-Aid. It's a blessing to be privileged enough that people trust the work of your hands. Your hands have been blessed, that people trust you, that you're not going to mess it up. If things don't go right, you're not going to crap on the company or say, oh, this is terrible. No, you're going to try to be like, well, how could I have done that better? And you're going to try to always be improving. And that's why when you talked about, seeing a video from 20 years ago and holy cow, okay, here's a story. I was smoking a cigar with Robert Stegman in Chicago. Robert Stegman was the inventor of canaloplasty, visco canaloplasty. He's from South Africa.
South Africa, yeah.
And we were smoking Monte Cristo number 2s, which I won't explain how we got those, but we were smoking those. And I leaned over to him and I said, and it just kind of occurred to me. I said, Robert, can I ask you a question? He's like, yes. I said, do you feel, and he was in his early 70s at the time. I said, do you feel like you're still getting better as a surgeon? Do you feel like, you're still improving? And he looks, we were the only ones there. He looks around. he goes, yes. And I was like, okay, good. Because I feel that. I feel every 6 months, I feel like I'm a little better.
Yeah, for sure.
Which is trippy, right? That in our 50s, we're like, we still feel like, man, I'm kind of figuring this out. I'm getting pretty good at this,
Right. For sure.
And I say that with fear and trembling, because I appreciate, but I hope but that's our whole lives, right? There's a restlessness to always be better and always come up with something that's safer for patients, that'll make their lives better, and I feel like a motor in me constantly, how can we do this better?
We always want to learn more. I always want to push the envelope, learn more, be an early adopter. So even my experience with ab externo canaloplasty basically was with the residents. I was at the county hospital. We didn't have any fellows other than a retina fellow.
I
had a young resident who was interested in applying to a glaucoma fellowship, and she said she wants to try this new procedure. It just came. I'm like, sure, let's do it. So we started doing it. And so, like, following your model there, don't ask permission, just do it, and then ask for forgiveness later if there's an issue.
Yeah, my wife rolls her eyes when I say that. She's just like, yeah.
But, you know, I think there's an important point, too, as well. But sometimes in academia, they're really stuck in the old paradigm of the way of doing things, the old mindset, as Osho would say, the old dogma. And sometimes when you push the envelope too much, you get a lot of grief. Remember, IOLs were called a ticking time bomb in the eye by a lot of academic people for many years. Like, never put an IOL in the eye, leave the patient aphakic. Yet those people who said that ended up getting an IOL in their own eyes.
Right. Well, it was a scam, right? I mean, those guys had it good. They had a nice optical deal going on. They were getting paid for aphakic spectacles and aphakic contact lenses, which I suspect was a large part of this. Was that they saw they were gonna lose a large revenue stream, you know. Maybe that's my theory. As I kind of, no one's told me, I'm just thinking that might be part of it. But I think about this all the time. This is actually really like, and I've asked lots of the leadership at ASCRS and others, just kind of like, hey man, I think our story is being lost. Like, I think the story of how, like, this should be a Hollywood movie, right? You know, the IOL story and the Thakos. I mean, Charlie Kelman's story is really compelling too. But
the amount of grief he got,
and it's you know, it's these forces of mediocrity and these or you know, forces of darkness, where you have this cabal of people that just don't want, they're fearful of their own livelihood. They're fearful. I don't think that they're fearful of hurting patients. I don't, because if you think about it logically, it's like, oh yeah, that makes sense. That should be a good goal. Helping people see at the time of cataract surgery with a lens. That would be a great idea. Let's figure out how to do that well. Right. But no, it was like he was basically almost criminalized and blackballed. Back when people could be blackballed. Now they're canceled, but they're not really canceled. But you know, like people would legitimately blackball people. He was blackballed.
Well, that means if you don't have at least a few naysayers, you're doing it wrong. If everyone loves you and you're doing an over-agrees and pat you on the back, you're probably not doing enough to push the envelope.
Right. I'm never the first guy that a company wants to. I'm the first guy they want me to do things, but I'm never the first one that they ask to do like a speaker program or something. Sometimes I am, because I have unique perspective. But you know, but because they don't, because I'm going to tell the truth. Right. You know, and if someone says something really stupid, you know, like I'm gonna be like,
let me ask you a question.
You know, like, you know, and here's why you're wrong. You know, Paul Singh and I were talking about this because, you know, Paul is so brilliant and such an effective speaker. And in fact, he was explaining to our wives our differences, you know, and he was like, well, you know, if something comes up and it's like, you know, and I admittedly, it's not something, you know, it's usually something that's not like a hill you die on per se, but you know, or Paul will say, oh yeah, you know, you could do it this way. Yeah, that's not a bad way. You could do it that way. Sure. And I'm like, no, you don't want to do it that way. Don't do it that way. And here's the 10 reasons why you don't want to do it.
Well, he's such a sweetheart. He don't want to step on your toes. So
you're right. And so like, that's always going to be, and you want that guy on the dais, you know, like, you know, you want him on everything, you know, and that's why he's on everything, because he's so uniquely gifted, you know, but you know, I'm the guy that like is the hammer. Like, I'm like, do you need me to like say something? You know, do you need me to say something? Because I will, and we'll get results, because I am, you know, logic on fire.
But, you know, I think we need that though in order to push the envelope. Because I just think back to how I was trained for glaucoma, which was in my training, hammer the eye with drops. So there are at least 4 or 5 different drops, which means they're using a drop every hour. Their entire day is spent putting drops in. And then maybe down the road, once the eye's a hot mess, now go ahead and try to do a tube or a trab, and then put the toxic mitomycin, let that cause lots of issues, and deal with all that. and then just watch them carefully as the vision slowly fades out. It seemed like that was what the dogma was.
And that's still the prevailing dogma in academics, circling back to academics. I mean, I hold precious memory in my time in academics. I mean, but I was always frustrated, not by the ability to practice the best medicine, actually.
Right.
I was frustrated by, the way the process was, and the fact that if there was an employee that was not doing things the way I wanted them to be done, they were protected somehow.
Yep.
And if they were people that weren't particularly great with patients or would say inappropriate things, like I had no power to fire those people, and they would just put somewhere else, and it occurred to me eventually that it wasn't fair for me to expect everybody to have my standards of excellence. But this was kind of a revelation, because is it fair to expect everyone to be able to keep up with me? I mean, really, and have my shared values?
But in private practice, you can. Private practice, you can. I've got people.
In private practice, I could. I could make people share my values.
Right.
In academics, I couldn't. And so, I was like, you know what? It's not these people's fault. It's not their fault. Like, this is my fault for still being here. And I need to and so it's been people like, oh, but people get sick of like the details and the running of everything. No, I love that stuff, man. Like, I have so much fun, like trying to, run have things be good, and even like how people answer, how the phones are answered.
Yep.
Like, it's a great day at Oklahoma Eye Surgeons. My name is, how can I make your day better? That's how they answer the phone in my office. That's how they go for it. But I mean, how can I make your day better? And it blows people's minds, because they're upset about a billing thing, and then they're like, well, I was upset about this, but like, well, you guys are having such a great day. I'm going to have a great day too. Yeah. Thank you for that. But those are things. What's that?
It's a big step for you to be in the university for, let's say, a dozen years, and then to say, you know what, I got to change gears.
14 years in Oklahoma and 2 years in Memphis. So yeah, I mean, it was I've still spent more time in academics than in private practice, but it's such a joy, even being able to, even with the declining reimbursements, like there are ways to be efficient, and there are ways to constantly be inventive, and really what I'm able to do. I was one of the busiest premium cataract surgeons in the university with zero. Like, if someone said, I want Dr. Sarkisian to do my cataracts, they would be told Dr. Sarkisian doesn't do cataract surgery. Right. Never mind that I was one of the highest premium cataract surgeons in the place. It's the glaucoma guy. So now and again, no, like precious memory, good people.
Yeah, of course.
But I now it's like a huge feature of my practice. I mean, I ended up first year in private practice being the first in the state to do the Panoptics lens, and
cool
things like that just kind of happened because I was like, I was there, and there's this, it just kind of, so I own 2 femtosecond lasers, which is like owning 2 Ferraris.
The lasers cost more.
Right. The lasers do cost, it's like, I love it. I love every part of that. It's so much fun to be able to, and then really that's the culmination, is the premium cataract surgery combined with, especially for mild glaucoma or ocular hypertension, some type of, MIGs procedure.
Yeah, for sure.
But even that's really controversial, because, I think when I was on the ASCRS glaucoma committee, we wrote a white paper about visual outcomes in MIGs, and basically showed that there's no real difference in the visual outcomes between cataract surgery alone. So it begs the question, like, for sure we should be fixing everyone's astigmatism that has glaucoma, even if they have severe visual field loss. If they have central vision, fix their astigmatism. But then it's like, what about like trifocal lenses in glaucoma patients? And like there was a meeting 2 years ago that I said, basically presented that, in mild glaucoma, which means, full visual fields, like, if they're controlled, go for it, And and I want to be as minimally invasive as possible. I want to have no chance of bleeding. So, I prefer the eye stand combined with the Panoptics if I'm going to do that, and or the trifocal of your choice, right?
Sure.
There's, I guess, a couple things to do now, and it's a prominent person came up and said, I am just so sad that, he didn't call me out by name, but because I wasn't the only panelist.
Sure.
That, with people that have decreased contrast sensitivity, that you would dare not give them the best resolution possible, and I remember I wanted to be like, well, there's 6 boxes of tissues up here. I didn't mean to make you sad. If you'd like to come up and have some tissues, that's fine. But, and then it occurred to me, what did Charlie Kelman say? He said, doctors debate, patients decide.
True.
Right?
So true.
And there is a point, and I tell my patients that.
Mm-hmm.
Like I say, if your glaucoma gets worse, you're gonna you may have some, you're gonna have resolution issues anyway. Right. But they want to read without glasses. Let them decide to read without glasses. Don't be a jerk. Don't be a self-righteous whatever, and decide for them. The first patient that had Panoptics in Oklahoma was a retired anesthesiologist with a huge superior arc visual field defect, but good central fixation.
Okay.
And I had got to talking with him for 30 minutes about this. At one evening, I just called him up and I said, "Here's the deal." He's like, yeah, I want to be the first one that gets that lens. And I'm like, but you got to appreciate that this is going to still have a blind spot. I don't care. He still emails me, hey doc, just let you know I'm doing great. Thanks so much.
All right.
I mean, the first week he was like, well, this one's a little darker. I'm like, yeah, that's your glaucoma, man. Oh, okay. I'm like, do you ever use glasses? No. And I love it. Thank you. Right. This guy's happy.
Right.
What are we doing here? Right? It's not about us. It's I think a lot of ophthalmologists don't want to have conversations with patients. They're going to make a decision. Here's another thing that really gets me. If you have glaucoma and you are on treatment for glaucoma, meds, or you've had intermittent SLT, which is my choice, I start with SLT, which I still can't believe we're talking about as should that be a thing? It blows my mind. You should not be doing cataract surgery alone on people that have elevated that you think that they have real glaucoma. They have a diagnosis of glaucoma and they're on meds, or they have glaucoma and you want to do something and they also have a cataract. Mm-hmm. Don't just do cataract surgery is not adequate. Yeah, it'll lower pressure, but it doesn't last that long. Mm-hmm. And you know what? Do you remember the prostaglandin wars? Every millimeter matters. So right. Are you telling me that cataract surgery alone is going to give you as low of a pressure as cataract surgery plus some gentle MIGs procedure? Mm-hmm. The evidence is clear that the MIGs procedure plus the cataract surgery will lower the pressure more. Well, is it more better? Why are we still having this conversation? Mm-hmm. And then I get to see all these patients that general ophthalmologists do phaco alone on patients on 3 meds with visual field loss when they come in with a pressure of 50 and, I don't know what happened. The cataract surgery should have lowered the pressure. Because you didn't address their glaucoma. Cataract surgery is not a glaucoma procedure. It lowers pressure, sure. Uh-huh. But now that when all we had was trabeculectomy, fine. I appreciate the phaco alone on someone controlled on meds. That right. I get. Although we did have ECP.
But then that begs the question: is part of the issue that we're not doing standalone MIGs procedures? Why not do it stepwise? Let me be devil's advocate for you here.
Right.
Why not do the cataract surgery now, and then 6 months from now, a year from now, you can always go back and do the MIGs procedure? Or is it a billing issue?
That is true. But what if and that I think we're going to see more of that. But why don't I'd much rather do a MIGs procedure at the time of cataract surgery, and then because you're in there already, and because every time you go in the eye, you lose endothelial cells. It might not be a lot, it might not be significant, but you're going to lose some. I mean, you look at all the phaco MIG studies and the endothelial cell loss, and all those folks started with a cell count of 2,500 to 2,900. And then, all the cataract surgery alone group had cell counts of like 1,900 after just phaco.
Mm-hmm.
Like, that's what you lose with phaco. And the phaco MIGs, they were kind of like the phaco iStent, for example, it was the same. It really was no different. Right. So you're going to lose cell counts every time you go in. And, I have lots of folks where I did phaco iStent, and then I'm now doing phaco infinite in the temporal quadrant. Sure. So I have people walking around with 5 iStents, or you could do ECP, or you could, take one of the stents out if it's in the way and do an Omni, or there's this new thing that Shawnee Anchalev has that is the cyclopen. That's an Alloflow, the scleral implant that you can put in the, there's other things you can, there's the thing is there's lots you can do. So, if you're a general ophthalmologist and you don't do all that, you don't want to do all that stuff, do something.
Yeah, for sure.
Or don't do it. Like, then send it to someone who's going to do that. I mean, like, there's plenty of folks that need cataract surgery. If you're not going to take care of people correctly or properly, it's indefensible. Like, if someone has phaco alone and they lose pressure because they lose visual field because they're being followed like a cataract patient, right. And that's indefensible. You're going to be, if you're standing a trial, like, why didn't you had these things available to you? You knew they had glaucoma. Like, why didn't you do these things? Well, I don't know. I don't believe in it. What?
It becomes a challenge there. Now, one thing that is, even since you've let's say 7-ish years, you've been in your own private practice, you're very busy. I still see your name on every single glaucoma trial that's out there. So you're probably doing more trials now than before.
Oh no, for sure I am, because I can control the process, and I can make sure that I wasn't hiring whoever was put with me to run the. Now I have this crack team where. They are so good at doing glaucoma trials. Really clinical trials are probably better. I've learned are probably better when handled in private practice anyway. Right. And we ended up being the largest recruiter for the IDOS TR study, which was awesome. And it just was one of those things. It worked out beautifully, and but when you do a lot, you also get compulsory audits by the FDA. So, but we made it through that beautifully, and so there is a flip side to being prolific, is that people are watching, but that's okay. You just got to be. You want to be perfect. You want to have everything be open and available to the most vigorous scrutiny, because you want to practice with integrity so that the results are. Like, they speak for themselves, so that without question.
Yeah, I've seen your name on everything. I saw you were on the TBT, right? Tube versus trab trial.
Yeah.
The Ahmed Bearbelt comparison. Yeah. And then now basically every single possible MIGS procedure, I see your name on it.
Yeah, Express versus trab, and primary TVT. Those were the things in the beginning. There was a there was a study I did with the Kruppen valve that became the Eagle Vision valve.
Okay.
That never really went anywhere. That was one of my first forays in being the primary investigator in a trial. And I got a bunch of my friends to try, and it just never really kind of went anywhere, but mostly because that mechanism was not that great. But yeah, the iStent Infinite, the CyPass, which is still upsetting. I'm still upset that I get it. But I have all these people walking around with amazing pressures after phaco CyPass. And I did a few off-label standalone CyPass, and they're doing amazing, and their corneas are fine. But yeah, if I left it too long,
but sticking out,
it was a problem. And so I've clipped my share of those too. But I wish they would have changed the directions for use and re-released it, because I have a lot of people who are not blind because of the CyPass, and I don't think we'll ever see it. I don't think that it'll ever happen. But Alcon, we're moving onward and upward. Like the DSLT. Now we were among the first to do DSLT in America, and man, that thing is fun. That is it's different because the patients are standing up. But here's the thing when I talk to patients is that it's a perfect laser every time. Because even if the patient moves their eye around, it tracks with them. And it's 120 spots, perfectly evenly spaced.
Right.
Like no human being can do that.
Yeah, of course.
Like no human being can do that. And so like I would do 100 spots, and just because I'm like, yeah, it's about 100. Yeah, 100 gets me around 360.
Right.
Well, this is 120, So we'll see. The data is good.
Perfect. Yeah.
The data is good. And we've had a lot of fun. But what I've seen with that is like I used to do, I don't know, like 15 to 20 lasers in an afternoon. And, now I'm doing 30 and getting done sooner, and
so why aren't more surgeons saying, start with first line treatment, let's do an SLT? Why are we even going into the debate of use drops first? Why?
There's multiple reasons for it. And we'll go over a couple of them. One, people are victims of their training.
Yeah,
they're victims of their training, right?
They don't have to be.
They don't have to be, but they are, right? I mean, they are. And, a lot of, especially the non-intuitive people, the people that had, the people that are like cut 3 times and, measure 3 times and cut once, and like, I remember I had a fellow that like, I never met when I put in a tube, I never measured how far back the plate is. Like I know what 9 millimeters is. Like I know and he's like, you don't measure. Like, how do you know? Like, this is not right. And I'm like, get your caliper and say it's 9.
Right.
I'm like, that's 9 millimeters. No way. Measure it right now. Do it. And then I made him do it for like the next 5 tubes. I'm like, get your calipers. So like, those guys will never get it. But
is that your way of saying get your shoe shine box?
I mean this with humility. Like it's being able to do that. It's a gift. It's not something. But I mean, don't tell me. Don't tell me I'm wrong because don't tell me I'm wrong
for sure
for doing something you can't do. But they're victims of their training, and I did my duty to try to correct that. For the people that I train. And then this is a little more controversial, but the House of Medicine has been bought and sold by big pharma, and I'm not saying pharma is evil, but they have a vested interest to grease the wheels so that the departments are funded well by pharmaceutical dollars, and so the paradigm of medical medicine first is in every subspecialty, and and especially the specialties that are mixed medical medicine and surgery are always going to get, but they're getting it. They're changing, especially because a lot of these companies now also have a rigorous glaucoma surgical program, and so they're getting the, I think they're gonna not divest them, but if you have a new drug, they're gonna be pummeling that. But all their old drugs that are mostly generic now, they're gonna they have the luxury of changing their tune,
right.
And so that I think that's a large part of it as well. And then part of it is just fear.
Mm-hmm.
I mean, it depends on where you practice. Like, I'm blessed to practice in a part of the country where my patients kind of do what I recommend. I love it when they don't. I love it when they ask questions, because if they ask questions, they're taking notes, they own it. Mm-hmm. Then because people just say, yeah, sure, whatever you say, but then they just, then you ask them a month later, like, what are you doing? What drops are you taking? They're like, oh, I don't know. Like, they don't know,
Right.
And then I think that there's a little bit of pride involved in some of this, because I think a lot of doctors don't really believe the compliance data. And the compliance data says, quite simply, that perfect compliance is 10%.
Wow. That's like 1 out of 10 pages has actual perfect compliance?
Perfect compliance is 10%. Now, we have all these these studies, these pharmacy studies that show that 50% of people don't even get their prescription refilled.
Mm-hmm.
Right?
Can you imagine? Yeah.
Right. So, and you just look up study after study. Now there's compliance. There's some compliance, like Doesn't mean people aren't taking their drops at all. You know, they might take them when they take them when they remember them, or they take them the week before their visit. You know, because you know they want to make you happy. They like you.
Right.
You know,
That's like me. I can't remember taking vitamin every day, so I take it whenever I remember. And then before I see the dentist, that week before, I floss really well.
right. Right. It's the same thing. So I think a lot of doctors have this sort of part like, oh, well, no, my patients.
Right.
They listen to, they do what I say. I mean, they listen to me. You know what? Half the patients don't even know who did their cataract surgery.
Right.
I'll ask patients, oh, who did your cataract surgery? Oh, I don't know. I remember I could think of his face. Well, you know, and this is very humbling because this is, and you know, I don't get upset. I'm like, you know what, this is a good check for myself.
Right. Yeah.
Right. Like, I'm not all that. I will be forgotten.
Of course.
You know, there are patients that will not remember my name a month from now, let alone 10 years from now. No one will give a crap about me in 50 years, and I don't care. That's fine.
If I want to be humbled, I always just talk to my kids. They'll tell me how little I really know.
Oh no, that's the best. I mean, you know, I have, you know, 4 kids and and you know, only I got 2 teenagers left, but the others are older, and you know that but you know the teenagers are happy to tell me, Dad, you're not as funny as you think you are. You know, although I usually win, you know, because I'll like do some funny voice or something and just be relaxed with it until they.
Well, I heard a good pearl for helping to convince a patient that they should do SLT. If they have resistance right off the bat, give them a drop like dorzolamide. Tell them to use it 3 times a day for a month. Come back in a month, and then ask them, how'd you do over the last month? Were you able to get all 3 drops in every day for the last 30 days? Do you want to continue that the rest of your life, or should we do the laser? And they're going to raise their hands and be like, please do the laser now.
That is a good one. And then the other is, you know, you could show them the data. Like, I think, you know, we have really good sleep study data now, and, you know, the light study that, you know, I mean, it shows actually that primary laser trabeculoplasty is not equivalent to eye drops. It's superior to eye drops, not just because of compliance, but because of how it flattens the diurnal curve. There's something about that 24/7 pressure lowering that, like, it's a superior treatment. Furthermore, to talk about sustained release, you know, the implantable pharmaceuticals.
Oh, like travel plus, sure. That you were instrumental in that study,
right? You know, and I did a bunch of Durista too. You know, and that, you know, there is data that shows that, you know, they're not equivalent. Topical travoprost and iDose TR are not, you know, equivalent. That actually the pressure is a little bit better with the iDose TR. And so, but not only that, if you have continuous medicine inside the eye, that will always be better than pulsing it once a day, even with perfect compliance.
right?
So, and the dose is so much, just the amount of the dose is so much smaller because it's right there. You know, if you think about it, like each one of those is the equivalent of like 2,080 eye drops.
Wow.
Each eye dose is the same as 2,080 eye drops.
Wow. That's when you put it that way. Wow.
Right. And then, I mean, you know, and I've seen how they're made. I mean, they're like, it's like honey, you know, almost the consistency of the pure preservative-free iDose TR. And then the other thing, people are like, well, you know, what if they get allergic? You know, the eye is kind of an immune privileged space in there, right? And it's anchored, it doesn't move, there's no cell loss. I mean, I have patients going out almost 8 years having had iDose. And, you know, there's no cell loss. Some of them will get, there's a 4% rate of iritis that's treatable easily. And, you know, like it's a remarkable thing. And, you know,
would that be the future protocol then for, let's say, a milder case? An implantable travoprost delivery every 5 to 8 years? Just
yes, I think that's going to be, I think that the standard of care is going to change fairly rapidly, where I think primary SLT for some, but I think there's going to be a lot of people getting primary primary eye dose. Many of my patients in the clinical trial were totally naive to therapy. They
Wow.
never had anything.
Wow. So their first glaucoma therapy ever.
I diagnosed them and I put them in the trial. And those were some of the best patients. Like, they did amazingly well. If someone's been on a topical prostaglandin forever, like, that's a different kind of patient, because all the uveoscleral outflow is it's already been messed with a little bit, you know. And when same thing with laser trabeculoplasty. If you have a virgin eye that's never had anything, not
That's
even
the
an eye
best.
drop,
Yeah.
and you laser trabeculoplasty, we're seeing 50% drops in pressure. Like, I've had virgin eyes with pressure at 35 be 15.
Whoa.
Yes.
Wow.
Yes. And it's incredible. But there's a big difference between a virgin eye and an eye that's been on eye drops forever. And
then you eliminate the issue of, like, what we're seeing, right, with the pigmentation of the eyelids, with the loss of orbital fat, the ptosis, or the
periorbital fat atrophy is something that it's kind of funny. Like, we didn't really hear a heck of a lot about it during the prostaglandin wars,
right?
And then all of a sudden, it's all we talked about, And I remember the ad for Brooke Shields was the first spokeswoman for Latisse, and you can't really even find some of those ad campaigns anymore, because it had her before and after, and they wanted to show the longer lashes in the after, but you could clearly see the periorbital fat atrophy in the after.
I'll have to Google that one.
Yeah, you could clearly see it. It was like screaming at you, and so I think they scrubbed the internet for those pictures, but maybe you can find them. I don't know. Anyway, yeah, good stuff.
Well, I think the paradigm is changing. I think we're in that, the benefit we have now, which we didn't have 20 years ago when we did our training, 25 years, the young generation's different. They're smarter than we were. They're able to pick things up very fast. That's why the CataractCoach stuff's so popular, which, by the way, is like, there's a huge amount of glaucoma in CataractCoach every week. But they learn things by video, and they learn it very fast. It's amazing. And I think that the younger generation is more amenable to rethinking diseases like glaucoma and rethinking what should the protocols be. And maybe the old paradigm is meant to stay in the past.
Yeah, they have resources that we didn't have, right? I mean, we couldn't just go watch a bunch of videos on iTunes, but there's something about that. Like, the value of fellowship for me was seeing someone do something well over and over and over again. Right. And because I'm an intuitive surgeon, I would see it, and then I would, like, replicate that, and you can, if you're, there's really, I mean, and there have been times where, I'm like, I've had to do some things, and I'm like, let me go watch I know how to do this. Let me just watch a couple of videos of this,
right.
And
pick up some tricks.
Yeah, like, let me just remind myself, like, how to, it's rare, and I'm certainly at the point of my career where if I don't feel like I'm the best to do something, I will send it to somebody else. But yeah, no, it is different. I agree, and and it's, I have a bunch of Zoomers that work for me, and it is as technicians who like, it's amazing how they get it.
Oh, for sure.
And like, they pick up gold mountainometry like that, and as long as they can get out of their own way, they're I mean, there's lots of there's hope for the future of America.
No, for sure. You know what it is? It's the generation also grew up like we did, playing video games. Hand-eye coordination is great. I could teach any of these people if you're enthusiastic and hardworking, even if you're right out of high school, I'll teach you how to do a beautiful Goldman application, or even other small procedures in clinic. You can do them. Yeah. No. So how's you were, are you enjoying just doing all your own surgery? Well, you were doing all your own surgery anyway. I always did the two in parallel. So I've been in private practice this is my 25th year. And so then I did academics for 22 years together, side by side. I got a kind of lucky position there.
Yeah.
But now I'm actually, listen, every so often you got to change gears. And a
So
few
you
years
weren't having residents do your cases.
No, my private practice was
Right.
always private practice.
Okay.
No residents, no fellows. And then I was with the residents of the big county hospital where we did everything. I mean, for example, someone asked me, like, have you ever done an almond valve? They asked me, it's like, I said, I've done more than 1,000. Because of the county hospital, there's at least one NVG case a week that we're doing.
Right. Amazing.
At a minimum, at least one NVG case per week. So we're doing that. And then on top of that, like, yeah, I actually learned by watching the CataractCoach videos. You learn so much more.
You really do. I think we've all picked up on things just, watching your videos and watching, just even if it's just a subtle something like, doing a stitch in a, backhanded in that situation or doing, like just these little things, like,
Right.
when I do the iDose on a left eye, I'll use my left hand because I want the iDose to be at close to 12 o'clock so the lid covers it. I mean, like, but little things like that you see someone else do, and you're like, I can do that. I can operate with my left hand.
But that's our commitment to lifelong learning. That's because you and I were the types where I always want to learn something new. Always.
Yeah. No, it's like, crack. Is we get addicted to new things, and and I would tell my fellows, I'm like, if I'm doing the same thing I'm teaching you 10 years from now, like, just shoot me. Like this is like, this is, so it was different. So Brian Francis and I and Jeremy Tan wrote a book, just MIGs, book, very practical book. And it was in the preface, I remember sort of talking with him like, well, how are we going to preface this? Because things are changing as we're writing the book. Things are getting FDA approved and things are starting
Right.
to be, we just finished the second edition. It should be out hopefully by Academy. And like, we had to get rid of all kinds of stuff that was in the first edition, like the gold shunt and, adductor canaloplasty. We're like, no, that's not MIGs. Like, now MIGs is really defined,
Right. Yeah.
and so we edited everything. But even in the beginning, in the preface, I was like, this is a template. This is a trellis of basic principles in order to do minimally invasive glaucoma surgery.
Mm-hmm.
The vine will be very different. The vine will constantly be evolving.
Right.
But the trellis is there, right?
Yeah.
And it's the same thing with all of ophthalmic surgery. There's the sense of the microscope and the sense of where you are, and when you're working in the angle, like, the landmarks are the landmarks. They're not ever going to change.
Mm-hmm.
Okay. Like, we're not going to have to do Vulcan eye surgery. It's the landmarks are the same, and so, once you have that and you just own that, and you're just, you're not going to, you are not going to implant anything in the ciliary body ever. That was a 2012 problem, I wish, I still see some of those, but yeah, I see more hydrous in the ciliary body than the eye stents, but it happens, and nothing against the hydrous, but this is what I see. But once you get that, then you have that foundation to build on. So that any new thing that comes out, you're like, yeah, I got this. This is, I live in this. This is my space, man. This is my home.
Of course.
And like, I can do this, and it's, and that was the kind of the premise of, like, this is all going to change, but it doesn't make the book obsolete. It's not like it's going to have a 2-year senescence.
Well, the fundamentals are the same.
Fundamentals are the same, and lots of light when you're looking at the angle, like, turn it up to 90%.
Mm-hmm.
Turn the light up to 90%. It's like, oh my gosh,
So it's easier.
I see everything. I've done that I did that with some trainees. I'll be like, they'll be like, yeah, I'm just really struggling. I'm like, just beep, 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 beep.
Yep.
Try it now. Oh my gosh, that's it. That's all it took to turn the light up.
Yeah.
It's a miracle.
Tricks. I had a trick on CataractCoach recently. I had a video of someone just using a little trypan blue dye to stay in the TM. Like, there you go.
Yeah.
That's easy.
Slick technique, right?
Yeah, nothing to it.
Yeah, I mean, there does come a point, however, where lots of the coolest ophthalmology on videos is what we call recreational ophthalmology.
How so?
Well, like the reimbursement for cataract surgery keeps going down. Reimbursement for everything keeps going down.
Right.
So if you start especially if you get the branded, I mean, if you're going to get it from a lab, the Trypan Blue, okay. But Vision Blue costs money. I assume they're still making that. I haven't used it in forever.
$66.
Right, $66. Right. So you start if you add that and a ring.
Yeah.
And
$120+ for the ring.
Right. So guess what? That case just lost money. You are now it's recreational ophthalmology.
And extra viscoelastic too. Add that in there.
Extra viscoelastic, and the fact that it took you twice as long,
right,
or 3 times as long as a standard phaco, right? So so there's the opportunity cost, recreational ophthalmology. But why are you doing it? Because you want to help that patient, and it's awesome,
right?
Once a month at least, I'm doing an LP cataract, and you know what I do for those folks? I mean, I'll often do them in my office, in my OBS.
Okay.
I own the femto there as well as the one at the hospital. I lease it to the one at the hospital to them, and I'll just heavily discount it. Sure. I don't charge nothing. In fact, I had a tattoo artist that had an LP cataract, that a traumatic cataract, and I'm like, can you paint me something? Paint me something cool, make me, because he's an artist. I'm like, make me a painting.
You don't want to get tattooed?
No, that's not going to happen. But although both you and I, if we put a little tattoo, right, we put a little tear here, and we hung out in the, I don't think anyone would mess with us. I think
wearing tank tops.
Right. Yeah. I think that we would be left alone. But yeah, I mean, I love doing femto in dense white cataracts to the point where I'm just because it's better. Yeah, you want to give people the best surgery, freaking Trypan Blue, and that's not the best surgery. It's good, and we've gotten good at it. We've done it hundreds of times, but just use the femto in those cases. It's way better, and I eat it a little bit, for those, I mean, I try to make it so I at least cover the click fee, but that's awesome. That is so satisfying, because then you're like, oh, this is now a routine case.
Well, this is why the insurance companies and Medicare can take advantage of us, because we just love what we do.
We love what we do, and we want to do the right thing.
The example you showed is you would do it for free. You're not profit zero.
Yeah, and you know what? Instead of it taking 20 minutes, it took 10 because I used the femto, and or whatever. I don't want to make up times, but I mean, it's, and then it just allows me to do more that day. But it really, in the end, what is it about? It's about that patient. I can't wait to see. This was last week. I can't wait to see what he paints. It's going to be interesting. I told my clinic director I may not be able to put whatever he paints up anywhere. Take
it home. Store it in your basement or your attic.
I've seen I saw his book of tattoos and of his pro, and I was just like, yeah, you're gonna have to work on something else.
A little too easy, huh?
Yeah.
Well, that's awesome. Well, the had a fantastic. By the way, we've been talking for an hour. I can't believe it.
It's amazing.
Yeah, you have a passion and a zest for this. Anytime I see your name, I'm like, all right, let me hear what he's got to say, because he's gonna talk from the heart and shoot from the hip.
It's true. It's dangerous. I'm not safe, but I am fair, and I am earnest, and I'm honest, and I'm passionate. I just love, man. How blessed are we to do what we do?
I'm thankful every day to be an ophthalmologist.
Right? I start to cry sometimes in front of patients. I'm just I can't believe I get to do this for you. I'm just overwhelmed that I get to do this for you, and I love every second of my life.
Yeah, especially those light perception cataracts. I mean, that's what got me interested in ophthalmology in the first place in med school. Patients with bilateral white cataracts. I thought I just witnessed a miracle. A little.
Yes. It's and you almost don't, when people ask, what do you do? What do you do for I never say, I tell people what I do for a living when I meet them for the first time until they ask me, because it's what do you say? Well, I make the blind, by God's grace, I make the blind see. Which is like, oh, okay, I guess you win. It's like, no, that's not what it's about. But it is kind of like, it's extraordinarily humbling.
Yeah, we're blessed. This is why I've been thinking, like, how can I ever retire from this? What would I do with myself?
Right. Oh,
right.
Yeah. You read all these blogs about like people doctors taking early retirement, physician burnout. And I'm just like, burnout. Like, I don't want it to end.
Right. I'm far away from that too.
God's gonna have to take me out of this game. We need to do this. We need to do this again for sure. This has been fantastic, and you need content, and
Oh, you're too funny. No, this has been fantastic, and I want to thank you so much. I definitely appreciate you spending this last hour with us.
Appreciate you, brother, and I look forward to seeing you at ASCRS, and let's come up with some mischief there. That'd be great.
Let's do it. And I want to remind our listeners and viewers, remember, got a new podcast every single Sunday on Apple, Amazon, Spotify, Google, and where you find the podcast, you find the CataractCoach podcast. Plus, of course, a new CataractCoach video every single day. And CataractCoach is not just cataract, it's cataract, glaucoma, cornea, and refractive, everything anterior segment. Plus, now we even have retinarounds.com. We got our retina channel with Dr. Pradeep Prasad, a new video every day as well. So until next time, I'll catch you later.